So a little bit of housekeeping. Please keep yourself on mute. We will address questions at the end of the presentation, but feel free to post questions in the chat as we go, and then we will bring them forward at the end of the presentation so you don't lose that train of thought or that thread, and then we can address it. An evaluation will be sent out immediately after this presentation, so please fill that out and send it back to us so we can keep getting better and better. So I'd like to do a land acknowledgement. Spanning generations, acknowledgement of the land is a traditional custom of Indigenous peoples, and when welcoming outsiders onto their land and into their homes, to build respectful relationships, acknowledging the land is an important part of reconciliation. It honors the authentic history of North America, its original people, and tells the story of the creation of this country that has historically been missing. And a shout out to Delray Dumont. This piece of Indigenous art is called Surrounded by Medicine, and she's an Alberta artist. So, to introduce Dr. Timothy Epp, is a professor of sociology at Redeemer University in Ancaster, Ontario, where he has served for 23 years. He received his PhD in social anthropology from York University, Toronto in 1999, following which he completed a postdoc fellowship at Kenneth G. Murray Alzheimer Research and Education Program at the University of Waterloo. His current research interests and publications are in the areas of disability, dementia, and personhood, the social history of race relations in Anabaptist traditions, and spirituality within popular culture. He lives in Dundas, Ontario, with his wife, daughter, and 2 lovable but crazy dogs. And with that, I will turn this over to Dr. Epp.
Thank you so much. And I'm really grateful to be here virtually with you today in Ontario, where I think it's about 8 above right now. I was checking the temperature in Alberta. I think slightly warmer here than there at the moment. But yes, and by the way, I'm presenting from home. And so at least one of our lovable but crazy dogs may wander by me. So my apologies for that already. Let me get into the presentation, and then again, if you have any questions, log them on the chat and be happy to talk to you at the end. So let's just begin here. Okay. And I'm hoping that you can all see that. And so I've entitled this presentation. Is it good?
Yeah, it's perfect. Thanks.
All right. Title of the presentation is just downsize this here. Title of the presentation: Care providers are people too, because of a couple of statements that some of my respondents told me when I was conducting the study. But it's focused on person-centered care. And just to give you a background here, MERIP was mentioned, the Murray Alzheimer Research and Education Program, where I became interested in the concept of person-centered care. But my PhD research had already taught me to think critically about identity. So whenever there's, for example, a term that's supposed to apply to everyone, we have to ask what the boundaries are of it and how applicable it is, even the term person. For example, my posting right now at Redeemer University, I conducted a presentation for Brown Bag Lunch, and I was talking about Tom Kitwood's approach to personhood and person-centered care. I think everybody around the table was either a professor of philosophy or religion, so I talked about personhood as a status we extend to each other in relationship. And once I was done, everybody said, no, you're wrong. Personhood is the immutable image of God in each one of us. And so there has to be some balance between these two ideas, I think. And my last point here, my own revelation or apocalypse, if you will, which means revelation, is thinking about the inextricable relation between our individuality and our belonging in community. And I think we tend as a society to emphasize one at the expense of the other quite often. Political theorist Neil Stammers says this, and this is important, I think, to the presentation. Once institutionalized, he's talking about human rights, come to stand in a much more ambiguous relationship to power. While they can still be used to challenge power, their origin and meaning as struggle concepts can get lost or be switched in ways that result in human rights becoming a tool of power, not a challenge to it. My point here is that the term person and personhood and person-centered care have been defined quite loosely, and some of the ways that these terms are operationalized actually frustrate the process of care and especially the identity of care providers. 1997, Tom Kitwood published a book called Dementia Reconsidered, and in that he challenged some of what he called the biomedical approach to dementia, which reduces the person or the individual to a series of symptoms. He says that the suffering of people with dementia is at least as much due to the social treatment as it is to the disease itself. And so he emphasized the concept of personhood, and that's what I was referring to a minute ago, that standing or status that's bestowed upon one human being by others in the context of relationship and social being, implying recognition, respect, and trust. And so then good care means person-centered care. This equation has emerged. If you want your long-term care center to be known as providing good care, you'll probably call it person-centered because there's this equation between attending to the person and good care. This is a very popular term. Recent a bit of research on one of our databases at Redeemer in a couple of weeks ago, I found that there's over 4,000 articles and books published on person-centered dementia care since the publication of Dementia Reconsidered, about 152 per year. So it's near ubiquitous. It's informing training for nurses, other frontline care workers, and again, this equation of person-centered care means good care. And it's applied to many different tasks, many different specific tasks like bathing and music therapy, behavior management, mealtime, preparation and serving, communication, life writing, so knowing the biography of somebody. But there are certain limitations to the literature as well. And the first is from an article that you can find online that I published a bunch of years ago. The term is near ubiquitous, it's everywhere, but it's often unclear. So what it exactly means or what it means in practice. And it's often reduced to what's called individualized care. So while Kitwood envisioned this relational model of care, quite often care is reduced to the individual, and then the individual recipient is assessed against our ideals of individuality, of autonomy and independence, and having a coherent biography, and being in the middle of a network of meaningful relationships. And some of the questions emerge about what happens when somebody doesn't have those things. Is that person still a person? There's a lack of recognition of intersubjectivity that, again, if we focus only on the individual, we tend to neglect the fact that our identities are relational. It's just not the individual that's in control of their life as our ideal would hold, but we rely on each other. Our thoughts, our emotions are shared, are relational, and there's a lack of attention to the personhood of relational others. Moving the bar. Well, you think about the criteria I just mentioned about autonomy and individuality and independence. You can say, well, okay, these people we thought about as non-persons are really persons because you can see some signs of self-awareness, but that still leaves other people beyond the pale as in the category of non-persons. And there are some fairly significant arguments we need to pay attention to. Peter Singer arguing that non-persons stand in the way of the fulfillment of life of real persons, and therefore it's not, according to Singer, it's not as evil a thing to do away with those individuals. So these are serious questions. Banerjee writes about the need to attend to the socio-political context of care, and this emphasis on individuality to some extent reflects what he calls a broader context of neoliberalism, maybe epitomized by former Prime Minister Margaret Thatcher when she said infamously that there's no such thing as society, there's only individuals and their families. And the quantification of person-centeredness. So one of the first things to emerge after person-centered care was introduced by Kitwood as a care philosophy was dementia care mapping, which has been, celebrated to a certain extent, but it's still kind of a quantification of a holistic relational approach to care. And there are certain problems in doing that. You lose something of that relationality as you begin to shift towards the numbers and minutes and number of people served and beds occupied. Banerjee writes about reductionism in the overall context of care. And so relational care is often frustrated by this dominant discourse of reductionism, which emphasizes assembly line care. Again, funding is based on quantified measurables. You need to report on a certain number of people served and beds and minutes, to get funding. Failure to treat human residents as human beings. Again, getting back to that ideal individual. If you're not that ideal, then chances are you are viewed as dependent and therefore need to be subjected to some level of control. The people we have talked to in interviews and focus groups have talked about the avalanche of paperwork. We've often been told, relational care is something we were doing a long time ago. It's nothing new to frontline care providers now because it's an official care philosophy of our organization. What we have is more paperwork. And the denial of voice. As we implement person-centered care, and it becomes this unidirectional relationship between a care provider and a care recipient, an individual, we often lose perspectives of care providers and family caregivers and persons living with dementia as well. So denial of voice. John Swinton published a book a few years ago, Dementia Living in the Memories of God, and he also critiques the way that personhood is operationalized in care. And this is a quote: "The capacities that are said to comprise personhood are always worked out by those in positions of power. Behind these types of debates lies a particular view of what human beings are and should be and what desirable human living should look like. To be a person means that one must be able to live one's life, develop one's potential, and develop a purposeful life course without any necessary reference to others." So that's how this relational model is often operationalized. And it's hard to escape this dominant discourse of this reductionist discourse, again, of quantification and quantitative measurables. And Lutheran points to the fact that the definition of personhood is often, again, in the hands of people with power. I'll get back to that point in just a minute. In a previous study I conducted, 2005, we conducted a study of 6 dementia care centers, and we're asking, given the ubiquity but lack of clear definition, how is person-centered care defined in practice? How does it inform the practice of care? What are the strengths of this approach, limitations, barriers? That study was funded by Social Sciences and Humanities Research Council of Canada. We had a multidisciplinary team, and we talked to care providers, administration, and persons with early stage dementia. And some of the things we found, well, that bit about paperwork came from that study. We also found that the phrase person-centered care could be defined differently by administration, by care providers, family care members. So a range of definitions. Okay, I said that. The term was unfamiliar to family caregivers and persons living with dementia. So one thing that appeared in that study and the current study, is that we asked family caregivers, what is person-centered care? And they generally told us, we've never heard that term. And the same thing with people living with dementia. We don't know what that means, but yeah, I would guess what that means might be this. So it's kind of a professionalized concept of personhood in that way. The frontline care providers talked about tacit knowledge. They said, care to me means imagining myself or a loved one and what kind of care I want them to provide or I would like to receive as a care recipient, and then applying that care to persons living with dementia. Tested care also was the communication that goes beyond words, recognizing bodily communication and trying to understand the person with dementia. And there's relationality in that too. There's some level of reciprocity in that, knowing each other and recognizing signals in the person with dementia. That there's some level of reciprocity there, even if communication is not always clear. And also, the challenge is to implement person-centered care in a context dominated by this, again, reductionist model of thought. That's where the RNs are saying, we're already doing person-centered care. Now we have paperwork. The current study. So out of that, a number of years later, I thought, well, why don't we revisit this study? And I'd like to think about what is going on in faith-based care centers, in part because of Swinton's writing, in part because I'd heard of other models like the Eden alternative and the greenhouse model, and that response from Redeemer as well, that, the immutable image of God in each one of us. How do faith-based care centers wrestle with person-centered care? Is it defined differently? Are there alternative models of care? What are the strengths, limitations, and barriers to these models of care? So that's what the most recent study has been based on, and that's what I'm largely talking about today. We conducted focus groups and interviews with 50 frontline care staff, just a couple of family and caregivers, and 9 individuals with early stage dementia. Frontline staff included healthcare aides, RNs, recreation therapists, therapeutic assistants, occupational therapists. And these were in 2 long-term care organizations in the province of Alberta. And the funding was from a Van de Zandt Family Restoring Hope grant that was offered at Redeemer to projects that were focusing in some way on mental health or some related field. And so this is one of the first recipients of that grant. And I'm presenting these findings to the Van de Zandt family in May. Last week, I presented these findings to another care providing organization as well. So, and your feedback will help me to revisit this and revise and incorporate some comments and critique into an upcoming journal article as well. So let's get into the findings from this study. Okay. The first thing we did as a research team, and I had a research assistant, was to do a survey of faith-based long-term care centers and dementia care programs, and we found about 80 or so across Canada, wrote these organizations a letter explaining the study. Several showed interest. In the end, again, only 2 in Alberta agreed to continue with the study. One of the things that happened was COVID. It was during a time of COVID. So that I think is a major factor in terms of the number of organizations that participated in the end. But in our survey and also in our focus groups and interviews, we found that person-centered care was the most common philosophy. So right away, some of the earlier questions emerged with the limitations and the way that this model is operationalized. So it appears to be the most dominant philosophy of care in both mainstream and faith-based care organizations. And again, we encountered things like the professionalization of personhood, that term that was only really used by frontline care providers and admin. We encountered the ubiquity of PCC, and our respondents told us as part of our education and training and the textbooks and workshops that it appears on posters in the elevators. We are assessed on person-centeredness. And the values that we were told as well were basically the same with the previous study: individuality, respect, dignity, privacy, independence. Faith did come into discussion at certain points, but where we wanted this to emerge organically, so we didn't really have questions that were directed at faith. We wanted people to begin to identify that themselves. And again, we talked to frontline staff, family caregivers, care recipients. Staff told us that person-centered care meant individualized care again. I have a quote reflecting that in just a second. It was customized to the individual. It was unidirectional from the care provider to the recipient, and was reflecting these values of rights and respect and dignity and patience, compassion, accountability, which often meant communication between staff and being accountable for the care that was delivered, the care that was promised was the care that was delivered, and creating a sense of home for and with residents. And that with is important, I think, because what care providers told us, and I should have explained this, I'm using care providers to talk about nursing staff and healthcare aides and family caregivers to talk about family. That with is important because frontline care providers quite often refer to some sense of reciprocity, of relationship building with the care recipients. So they're living in this, they're working in this tension between the reductionist model of care and the relationality that they often identify and practice. Family caregivers said person-centered care, well, we don't know what it is, but we imagine it probably knowing our loved one, respecting our wishes, having care staff accessible, making our loved one feel at home. So we're kind of guessing at what the term might mean, respecting family relationships. Care recipients mentioned very kind of tangible, practical things that are valued, being at home, getting good meals, positive environment, engaging activities, attention to faith, religion. I feel at home because I'm allowed to pray. Support for daily tasks. So, hygiene, the staff helps me brush my teeth or bathe. But they also talked about relationships with staff as so important, knowing staff. So here's a definition from staff about person-centered care. You customize everything to that specific person in terms of culture or needs or food, or you make sure that they do what they did all their life, like their habits and cultural things and religion. You offer them choices in everything. That's what that means to me. Family, this is one family response. Have you heard of person-centered care? I don't think so, but I know what it would mean, that you center on each individual and their needs, and you try to meet their needs as best you can. And here's something from one care recipient. I'm enjoying myself. They call me by name. They don't call me a client or resident, which is interesting because I talked to the frontline care providers. I said, well, what do you call the people who you provide care to? And almost everybody said residents. But here, somebody receiving care said they don't call me a resident. My name is on my door. People know my name, so that is good. So it was those very personal kinds of things that were valued by the care recipients. People know my name, so that is good. Staff often emphasize reciprocity, co-creating care through interactions with care recipients. So they talked about knowing and trusting, building trust together with the care recipient. But that existed in a tension with what I've been calling the dominant model of unidirectional care, of kind of one-way relationships, of identifying the care recipient as only a recipient and the provider as only a provider. There's other tensions as well. So that quote from the staff about tailoring care to the individual, well, then staff would quickly say, but that's hard to do because this is a congregate living situation, and I'll get into other factors that complicate that in just a minute. The holistic philosophy of care, of relationality and person-centeredness versus the context of care, something I'm repeating over and over again, that overarching emphasis on care as quantitative and very medical. Okay, so staff also talked about person-centered care as not only relational, but as a strategy, a marketing strategy that's used by their care centers to put them on the map. That's what several people said. The healthcare aides said that's how they sell what they're about and their expectations. Occupational therapists said saying we're person-centered puts us on the map, because when people look at our values, part of them is their faith base, along with person-centered care. You say Christianity to people, they go along with that because a lot of people are Christians. The faith becomes a center that puts them on the map because of their values. And while that it can be seen, as in a positive way, what these staff are also saying, though, is sometimes it's used primarily as a strategy. Again, that equation of good care equals person-centered to put our organization on the map. And then, well, does it still mean relationality is mostly a marketing tool, especially when family caregivers don't recognize the phrase. The values of staff told us that we're informing their care, the person-centered care. Again, I said these already. I think respect, respect often for identity, so biography of somebody, but the autonomy. So as much as possible to let somebody make their own decisions, but then that quite often is difficult because of the congregate living situation and attending to each individual. Dignity, privacy, examples were, if I'm giving somebody a shower, make sure the door is closed. And so those are very practical aspects of dignity. Choice, giving choice as much as possible. Patience, compassion. So we talked about those things already. But again, emphasis on individualized care. And that's a bit different than what I feel Kitwood was trying to get at with the relational care. And people are not only individuals, but they're also in relationships. So individuality sometimes is, I think, overemphasized in care, especially it gets difficult in a congregate situation. Family caregivers talked about values and practice, but they were very critical. I see values listed here, generic set of values. There's a lot of rule following, like your mom can't eat your lunch in the dining room because there's X, Y, and Z. Often when I'm there visiting my spouse, you can't find a nurse anywhere. I had the spouse in for 24-hour care, but one of the nurses that was on there said that this isn't 24-hour care. If you want 24-hour care, you need to pay for it. And the person identified that's not necessarily the staff's fault. It's the organization that doesn't hire more people, which becomes another element in this perfect storm of things. Some of the phrases that come to mind are perfunctory, rule adherent, and routine. There've been a few individuals who really seen my family member as a person that doesn't feel like it's part of a policy that's governing what's going on. So family caregivers were quite critical. They didn't see the values they imagined as part of person-centered care in practice. Persons with dementia identified things like love and affection and home and choice and respect and dignity as a kind of care. Now, they didn't recognize the term person-centered care, so we asked, okay, what kind of care do you think person-centered care is, or what kind of care would you like to receive? And this is what they told us. What is important in care? Well, staff said individuality, again, doing for somebody, but also, and task completion, but also relationships. When you go to work, the person you care for, you know exactly who they are. There's something wrong, you can notify the team. So it's, again, this tension of knowing, doing for, completing tasks, but relationality is always there in part. Sometimes tasks were emphasized more than relationality. Make sure that they dress up, that they're not incontinent, they're not sitting in their urine or bowel movement. But then this person went on to discuss family satisfaction. When the family says, we're glad you're here, we love you, when they're happy, then we're happy too. So this balance between completing tasks and engaging in relationships. And sorry for the number of quotes here, I just kind of like these all. PCC means patient-centered. Sometimes the term patient was used. Patient in the center, considering their voice, their own decision. We listen to their voice, consider whatever they decide. This also means the patient knows the caregiver. If you know them psychologically, emotionally, and physically, it's a holistic approach. You should know the patient. So every time you do the care, it's a way of talking to them, of communicating with them. Listen carefully. You don't need to rush them. Listen attentively and carefully to what they want. So these are hinting at some level of relationship of reciprocity. Even if the residents don't recognize you every day, if they hear your voice, always let the time the residents will trust you. I soften my voice to give them reassurance that they will trust you. Again, relational care. And this, again, was something that staff told us they've been doing for a long time. And the official approach to person-centered care was something more recent. And staff didn't always feel that they were listened to in terms of their experience of delivering relational care. Staff were also asked what they felt the residents really wanted from care. And some people said, well, task-oriented, washing them properly, taking them for a walk. But others said, they want to feel at in their own house, that they're with their families, building relationships with them, making positive differences in each and every one of their lives, to be reliable so that they know that you're there for them, that they feel support from us and understanding. So again, there's always this tension between tasks, relationship building, from the caregivers, important elements of care, what's important to you about the care that your family member receives. Staff knows their loved one, respecting our wishes, accessibility, availability. Staff makes their loved one feel at home, respects our relationship between our loved one and other family members, like spouses and children. So a lot of, wishing that staff would listen to the family and residents or care recipients. Again, in part saying, doing for what the staff does for me, but also relationships. I meet people here, they're happy. The staff give you a lot of help. One thing I really enjoy is the people that are here now, they do a heck of a good job. One of the most time-extensive questions that we ask, though, so staff know the values and they recite them almost, word for word. They're unanimous in their knowledge of values. But you ask staff what the barriers or challenges to person-centered care are, and there's a bunch. And I call this a perfect storm because staff, again, quite often say, we've been doing this relational care, and now it's really hard. One, the organizational structure. So again, implementing a holistic model of care in a congregate living situation, but also the physical environment. Staff were talking about, old lifts or washrooms that are too small to allow anybody to try to do anything for themselves, or other aspects of the physical environment that were barriers to providing person-centered care. A major one was staffing, chronic understaffing. And so staff would say, we want to do this. We want to deliver relational care. We do not have time, which is the next element, based on the understaffing that we're experiencing right now. Healthcare areas are talking about doing kitchen work because there's not enough kitchen staff. So time and staffing went together. Limited time for relationships due to staff shortage, also cutbacks, limiting staff hours. So some staff were cut back from 8 to 6 hours, and then didn't have enough money to feed their families, so they had to work a second job. Complex needs, I found very interesting. So staff were telling us that the government at that time was emphasizing aging in place, keeping your loved one at home as long as possible. But then they say, but then when somebody does come into the situation, this long-term care center, which is already understaffed, not enough time for each individual to deliver relational care, these individuals are coming in with complex needs. They're at advanced stages of dementia. And so behavior becomes challenging, sometimes aggression, wandering. So then resident care risks become part of the mix, balancing individual choice and safety. If you want to deliver choice, what are the limits to that? Where are the risks of giving people choices, especially as there are many people to attend to? Again, thinking about how this is compounded by thinking of what staff are telling us about the current government policy. It sounds great to have aging in place, but not enough attention is given to what happens when people are coming into long-term care. Lack of support for staff. And this is where the title really comes in. Staff are telling us, yes, we know the model of person-centered care. We're trying to deliver it. We've delivered it in the past. But it seems to us like this is only for the care recipient. We don't feel affirmed as persons ourselves. And we're caught in the mix of this tension between relational care and this dominant model of, quantified measurables and understaffing and not enough time, this perfect storm of everything. Family relations, family don't understand what we're trying to do. And if there's only family education and that socio-political context, several staff told us there used to be more dementia care units. Now there's been several closures of long-term care centers, which leads to more individuals in our care center, but we're understaffed. We don't have enough time. It all kind of, again, it's back to that perfect storm. Right. So here's one of the examples of that tension between, choice and congregate living. Very easy for us to offer choice. What do you want to wear today? But when someone's demanding extra attention that takes away from other residents, that becomes part of a problem. Could be an expectation of families. We spend extra time with them. In reality, we may not be able to. Don't get me wrong, we'll spend time with residents whenever we get a chance, but the staff are taking their breaks and things like that, and that's super important. Working above and beyond is great, but when it comes down to staff safety, they have to take their breaks and they can't stress over doing things. That's part of the problem for me anyway. That's from a healthcare aide. Sorry for all the quotes. Healthcare aides talked about it's easy to become task focused. You got a certain amount of time and stuff to do. So it's hard to maintain that relationality. Every resident is different, behavior is different. You don't have time to go one-on-one. If there's 5 of me, need to take care of myself too. Very difficult to do as much as person-centered care as you'd like because there's still huge time limits. Time is always a barrier. Not enough staff to go around. We do our best to give the residents that assurance, but there's no time for talking, singing, cracking, jokes. Just to let them know they're feeling at home, away from home. That's their home now. They're depending on us because they don't see managers every day. They depend on us. They see us every day. Families depend on us. We interact with families more than management does. Our responsibility as a healthcare aide, we're dealing with 10 residents for 8 hours in that span of time we're delivering to each resident. Does person-centered care really work when you have to care for 10 residents on an 8-hour shift, serving 2 meals, cleaning the rooms, and doing their laundry? Family recognizes this to some extent. The staff is doing their best. It's not the staff's fault. It's organization. I think they need to have more staff to feel that they can make a difference in someone's life, not just a job, not really paying them enough. Most of the people are immigrants. That's something else we found, that that many of the people who were in our focus groups or interviews, some of them identified, for example, as Filipina. And I thought many of these workers could probably fit into a visible minority group. And I began to ask questions about, personhood and racialization and whiteness, and maybe that needs to be pursued in another study, and how new immigrants, for example, who are working in the healthcare field might not feel like they're being affirmed as persons. So again, that's something for another study. Okay, tensions, the need to educate families, amount of clinical time. So usually the family's not giving support. And so this person was saying we really need family members to understand the tensions we're living with here. The next step up from person-centered care is not just to focus on the person, but the family-centered care needs to be there. Okay. Sociopolitical context, I think they're sending more people here with more complex issues, not just easy to care for them with the amount of staff we have, creates problems every day. The government says they want people to stay in their homes longer, put in home support. Those families get used to having one-on-one there. People are staying in their homes longer. And yeah. Okay. We need to be more realistic about the people who are in long-term care. And there's no PCC for staff. All the kitchen staff, housekeeping staff get laid off. Healthcare is talking about doing kitchen work. If we have a problem, there's no management coming to help us because they think we're equipped and we know exactly what we're doing, but we still need people there. We need management with us. They're just leaving us. Person-centered care is only for the residents. In reality, we're not just working with the residents, we're cleaning the room, we're kind of housekeepers, we're washing the dishes. Whereas this person-centered care really, it's not for staff, it's about putting the organization on the map. There's no person-centered care for us, it's about the residents and their families. So, one thing getting back to that faith based care center idea that I've been musing about is my understanding is that faith-based and mainstream care centers quite often are accountable and receive their funding in similar ways. And so some of these same pressures, I think, are common to both categories of care centers. But again, the dominant care philosophy. Next steps. Well, people said we need to have a more of a systems model of care. And some of the literature now has begun to publish arguments on relational care. So recapturing some of Kitwood's original vision, talking about relational care, critiquing the elements of person-centered care as it's been operationalized and saying we need to really get back to valuing every single person who's involved in the network of care. Care providers, care recipients, the families, everybody. And to have more education, to understand each other's roles. Attention to intersubjectivity, to realize the perspectives of everyone, and that the care recipient is also always part of these relationships, even if they're not communicating in the expected way. These relationships are very important, and we need to include people in our model of care. A shift towards family-centered care, educating families, and valuing families. And my last point here is thinking about how this relates to my understanding of scripture. Mark 12:30-31. Think about loving your neighbor as yourself. So care is not just one direction. It's valuing the providers and the recipients and the families. And that verse means not only loving your neighbor, but loving yourself in the process. So that's it.
Okay. Well, thank you, Dr. App. I just want to jump in here, and I do have a question here. One is it possible to get a copy of the presentation? Okay. So I will get that and I will send it out after the fact. Has your study, I have a question, has your study affected any change in policy or practice since it's been done?
Well, we have sent an executive summary and a full report of our findings to the two care centers. As to how it's affected practice, I'm not entirely sure. We haven't received any response from the care centers.
Yeah.
So, but we've let them know what we found.
Okay. Is there anybody else that has any other questions? I am not seeing any. So, just had somebody jump into. No, I thought I missed a hand raise. Okay. So what I'd like to say is if you think of any questions in the future, please feel free to email them to me and I will pass them on to Dr. Epp and we can answer those.
I think there was one question, just to go
yeah,
in the chat about the government.
yeah, we're getting some pop up now. So what role does the government play in all of these?
Yeah. So, I mean, what we know is what we were told by staff and family members, and that is the context of care, the parameters of care to a good extent are influenced by the current social political climate. And so, you know, there are discrete pieces to this. For example, that concern about not paying enough attention to the what happens when somebody who's been in family care for so long eventually comes into long-term care, that transition piece. Staff especially were feeling it is not attended to very well. There's all this idealistic rhetoric about aging in place, which could perhaps also be seen as downloading things to the family, right? But then they're saying there's not enough attention to the complex needs then that individual has when they come into care. Also, those closures, several staff told us about closures of long-term care centers, reducing the spaces for people, which compounds things with the understaffing, the lack of time. And so you have again, in the end, our focus largely was towards the care providers because there are very few family caregivers, and the care recipients had a few things to say, but mostly the comments came from the care providers, and they're saying they felt kind of caught between the kind of care that they wanted to give, but the kind of care that they felt also pressured to give in this social-political climate. So, in terms of funding, and so in terms of providing more spaces, I think the government has a key role to play.
Okay. Are there direct services that help with that, the propensity now to age in place that for transition into long-term care?
Yeah, that I think should be explored a bit further, and I'm not entirely familiar with the Alberta context. So, but I think that really needs to be explored as well. Direct services and a general understanding. I mean, staff told me that they didn't really feel equipped to deal with the complex needs that people were entering with. So, greater understanding of those needs, but also greater support for the staff to provide the care. And in the end, again, sometimes that phrase person-centered care seemed to be more of an organizational promotional strategy than actual attention to the well-being of people involved in care.
I have a few more comments here. It says, one from Marianne says, thanks for the presentation. Relational versus unidirectional piece is very interesting. Thank you for your research and presentation. It aligns well with my observations and experience in working in long-term care. And thank you. It's a good presentation and resonate with what we encounter every day as healthcare providers. We heard the same responses from staff and family. So a lot of kudos and thank you.
Well, thank you. And maybe I should clarify one point, because last week in the presentation, there was somebody from an administrative position who was listening, and he said, well, but care providers, they're there to provide care, and care recipients are there to receive care. And then I'm not talking about care recipients caring for providers in the same way, but I'm talking about valuing each person who's part of the care process. And if the care providers don't feel supported, if they don't feel valued themselves, I mean, I'm sorry, I'm going back to scripture again. We love because we're first loved. You got to feel valued in order to give value, I believe. So that's the kind of care that I'm talking about.
Okay. Well, I want to thank you very much for your presentation. Again, if there are any further questions or comments, I can make sure that they're forwarded to Dr. App. And I thank everybody here for attending today. And please fill out our evaluation.
Thank you for inviting me.
Thank you.